Alright guys, so here's the second half of the genetics lecture, and this video is going to be broken into really two parts. There's a questions at the very end, and for the first, say, 15 minutes, it'll be when I taught in person. One of the topics that I taught was genetics, so I made this little kind of presentation of just the highlights of each of the topics. So we put them in all the categories, pretty much like autosomal dominant, autosomal recessive, and then I want you to at least write out two key things for each one of those. So when you make your sheet, you can actually put those next to it, so you can memorize the categories, everything that's in those categories, and then two key points with each one of those. And then I think you're set to where you can work through each problem, because on the STEP exam they're going to give you all the clues. You're going to have to make the diagnosis, and you're going to have to perhaps work your way backwards. I mean, that's just kind of how they do it. So for the first 15 minutes, it's just me kind of talking over my presentation. So if you just want to skip all the way to the questions, kind of find those pretty much halfway through the video, and hope you like it. Okay, so first thing up, we got the autosomal dominant. That little acronym is going to be very powerful dominant humans, and you can see where the one that's the letters that are underlined are going to be the conditions, and you know that, again, autosomal dominant, every generation is affected, males equal females. That little thing there says variable expressivity. Essentially, it's like that neurofibromatosis that you'll see in a second. Some people get it pretty bad, some people don't get it as much. But again, the V, again, very powerful dominant humans. You got to know that, okay? And so the V, von Willebrand's, how they asked that. Some of the findings, that increased bleeding time, yet PTT and PT are normal, okay? You got to know it's a decrease in the von Willebrand factor. That test, they could ask you that it's the ristocetin test. And then obviously you treat it with desmopressin, and I think that was, I've seen that as a question. What's the treatment after they describe von Willebrand's? Von Hippel-Lindau. The key with this one is it's at multiple tumors, and again, von Hippel-Lindau, 3 words, it's on chromosome 3, as you can see there. And the von Hippel-Lindau gene is a tumor suppressor gene, so if you got a deletion of that, what are you going to get? A bunch of tumors. For the pseudo-hypoparathyroidism, if you ever listen to the Goulian audios, you would know that he always says that knuckle, dimple, okay? And so it's a defect in the G protein. Now, after we do a video on basically pharmacology, we can talk about the G protein, and that's in my notes down at the bottom right, that it's basically there's a defect there, and that's what's meant by the end organ resistance to the parathyroid hormone, because it's a G protein linked, but that's the condition of pseudo-hypoparathyroidism. And then myotonic dystrophy, this is one of those trinucleotide deals. It's CTG, and that's why the myotonic dystrophy up there, the T is in red. Okay, and I think on this one, all you really have to know is just that it's CTG, and the look is pretty distinct. Osteogenesis imperfecta, and this is the one you got to know that they're going to try to trip you up and confuse it with child abuse. Okay, but you got to have that blue sclera. It's type 1, most common, and again, type 1 collagen defect, but this is the one, again, child abuse is going to be because of all the brittle bones, so you have to know that. Osler-Weber-Rondeau, this is that one. It's just that description. It's the AV, or I guess they're calling it now hereditary hemorrhagic telangiectasia. It's kind of an AV malformation, and so they don't have it goes from arterial to arterial to vein, and it skips the little blood vessel, and if you skip that, then you're going to have these red marks, okay? But anyways, it's more of the description when it comes to Osler-Weber-Rondeau. Know that it's autosomal dominant. Marfan syndrome. The key with this one, obviously, it's the look. They like to kind of confuse this, with some of the other conditions. The one I like about this is that know that it's upward subluxation of the lens, and I think it's I want to say it was homocystinuria was the one that was downward lens dislocation, but upwards lens dislocation, it's Marfan's, and that makes sense because you're always looking up. These guys are really obviously tall, and it's a defect in the fibrillin gene. Okay, those are the things I would know for Marfan's. Acute intermittent imperfora. I never really memorized this one too much, other than just the red wine colored urine. Otherwise, it's just it's so distinct. But I'd go red wine colored urine, and it's that porphyrobilinogen deaminase deficiency. I'd have that one down. Neurofibromatosis, autosomal dominant, no type 1, type 2. Obviously, the type 1 is the one it's more classic. The type 2 has that acoustic schwannoma, okay? And then neurofibromatosis 1, it's on chromosome 17, and I think if you count the letters in neurofibromatosis, there's 17 of them. Pretty distinct. But this is that one that, some people get it pretty heavily, some people don't get it as much. Achondroplasia, the short limbs, the trunk and everything looks pretty good, but then the arms and the legs, and if you look down at the bottom of the notes there, it says endochondral and intramembranous, because it's the endochondral is how the long bones grow, and so that's affected in achondroplasia. The intramembranous type of bone growth, that's the flat bones, and that's not affected, right? Because that's like the ribs and the and such. So no, because I can see that being a good question. What kind of bone formation is affected in achondroplasia? And you're going to say endochondral. Okay, and again, fibroblast growth factor is affected. It's a defect. Androgenic alopecia, just like it sounds like. Adult polycystic kidney disease. The question that seems to come up on this is, what's the most common extrarenal manifestation? Outside, obviously that means outside of the kidney with this condition, and you're going to say it's the liver cyst, because Berry aneurysm, people want to jump on that, but that's the most common cause of death. But the most common extrarenal manifestation is going to be the liver cyst. Okay. Noonan's, never really memorized too much on this, just knew it was in the category of autosomal dominant. Tuberous sclerosis, you always see this when it comes to add those ash leaf spots that you see, and also it's like the seizures. It's got to be under differential with the kid with seizures. And if it's seizures with ash leaf spots, you got to be thinking tuberous sclerosis, autosomal dominant. Hypercholesterolemia, autosomal dominant, obviously the LDLs. It's elevated LDL due to the defect in the absent of the other receptor. 700 plus, that's big time. And they have that little xanthoma picture right there. Huntington's disease, they love this one on the STEP exam. Trinucleotide repeat, CAG, okay? It's a CAG repeat, and that's with those flailing arms and those kind of jerking choreoform movements, okay? Caudate atrophy. Hereditary spherocytosis, this is the one you're going to memorize with the MCHC. It's pretty much the only thing out there that's of any significance where there's an increase in the MCHC. You're going to be thinking hereditary spherocytosis. It's like they're a giant circle per se, and they don't have that kind of indentation, and that's what it looks like on the slide. Okay, and this is the one where, again, splenectomy would be the treatment. Don't worry about that. That's more of a step 2-3 when it comes in the treatment aspect. Defect in spectrin or ankyrin. Okay, hypertrophic obstructive cardiomyopathy. Again, large heart. I think this was on my step 1. They showed a picture, and the heart looked essentially like this. Again, I forget how I think they just wanted the diagnosis of it, and it was just simple like that. But you better know that the mechanism is a defect in the sarcomere proteins, and this will really get the sudden death in an athlete. So that's the autosomal dominant, very powerful dominant humans. And if you go through all those and you write them down, you need to drill those and make sure they're in that category, and then just know 1 or 2 things from each one. It'll work. Next category is autosomal recessive. You can see where it kind of skips a generation in there, and then you can see, like I said, those arrows often complete penetrance, and more so earlier in life. And if you're when in doubt, if you have no idea on step 1, think autosomal recessive, because that's where most of the enzyme deficiencies are. Okay, so albinism, the key with that one, know that it's tyrosinase. Okay, it's a deficiency in tyrosinase, and when we do the biochem lecture, I'll make sure I kind of emphasize that. Don't think it's a melanin issue. That's not what it is. It's a deficiency in tyrosinase. And then the autosomal recessive polycystic kidney disease, again, kind of same thing applies. Obviously, it's autosomal recessive. It's in the name, but the most common extrarenal manifestation is going to be the hepatic cyst. Okay. Beta thalassemia, there's really nothing kind of self-explanatory on that. Cystic fibrosis, if you listen to the lecture here, when we get to the questions, I'm going to describe that one in detail, and I need you to know the difference between where you're at, whether it's a sweat gland or lung, pancreas, elsewise, okay? Very important. Deafness, and then emphysema, and that's going to be your alpha-1 antitrypsin deficiency. So just know those. Friedreich's ataxia is going to be, that's the frataxin gene, and this is going to lead to iron buildup, okay, which is a free radical. And then we got Gaucher's. And then, again, I'm just rattling these off just so you have them. You need to write these down and make sure you get them in the category. Galactosemia. Glycogen storage, okay? Those are always kind of tough to memorize, but if you just know it like this, von Gerke's has the hypoglycemia, okay? Von Gerke's, hypoglycemia, has the hepatomegaly, that's fine, but they all tend to have a lot of that stuff. But von Gerke's, I want you to go hypoglycemia. Cory's disease, third one down, is basically a poor man's von Gerke's, okay? And then Pompe, I want you to think the heart, okay? Pompe, cardiomegaly. Yes, you do have to know those deficient enzymes. You're going to be complete. But if you just know those are the big three, von Gerke's, hypoglycemia, Cory's is a poor man's von Gerke's, and Pompe, you're going to think cardiomegaly. Hemochromatosis, again, the bronze skin. Hurlers, I really didn't, I didn't really memorize that one other than the corneal clouding. And then these lysosomal storage, for these recessive ones. I'm not going to bore you through these. All these were taken straight from the Step 1 book when I taught this. And you just have to know, actually, Fabry's is going to be X-linked recessive. Everything else, including Gaucher's, autosomal recessive, Niemann-Pick. And if you look at that thing on the bottom right, where it's ceramide, and then it goes out with Niemann-Pick, Gaucher's, and Krabbe's, if you look at the thing going with the arrow pointing in, sphingomyelin, glucose cerebroside, and galactose cerebroside, all you got to do with those is just put ACE at the end, and that's the enzyme. So in Niemann-Pick, it's sphingomyelinase is the problem. In Gaucher's, it's glucocerebrosidase is the problem. And then Krabbe's is galactocerebrosidase. That's the enzyme that's deficient. For Niemann-Pick, I always put that, I drew like a little, a red eye for the cherry red spot on the macula, but then I drew a nice big liver next to it. Because in Tay-Sachs up there, I drew the cherry red spot, the eye that's red, but then it did not have a liver because there's no hepatomegaly. That's how I differentiate Niemann-Pick versus Tay-Sachs. But the enzymes, again, just put ACE next to those things at the bottom. This PKU, again, when we get to biochemistry, we can nail this whole thing going through here. I wouldn't, don't sit there and memorize it for right now, but just know that PKU is in this category, and because you need to know all those enzymes. They're really important, and it's the biopterin one too, but we do a good job when it comes to the biochem. We really nailed that one, actually, so stay tuned on that. And so that was the autosomal recessive. That was the big category. When in doubt, you're going to put autosomal recessive if you have no idea. X-linked recessive. This is the B-Wise, Fool's Gold, Heed's, Silly Hope. Again, Bruton's, Wiskott, Fabry's, G6, Ocular, Leishman, and so on. So going through these, Bruton's, B-cell, it's a disorder of the B-cell maturation, mutated tyrosine kinase, okay? 6 months of age is when it kind of comes the most prevalent, because that's when like the mom's passive immunity starts to subside after that time. Wiskott-Aldrich, you just got to know that acronym WAITER, and so you'll get that thrombocytopenia. So anytime there's a kid has that low platelets, you got to be thinking that, recurrent infections. And then there's the Fabry's. That was that odd man out, right? Was Fabry. When I think Fabry's, all I think about is kidney, renal failure, okay? G6PD, you always see this one. This is that guy from the Mediterranean or African American that has, whenever they get an antibiotic, they start having like anemia and then colored urine and stuff like that. So I always think G6PD, but know the inheritance. Ocular albinism, Leishman, you better be thinking it's that HGPRT, mental retardation, but the key thing here is they're the ones that start chewing on themselves and stuff like that. Leishman. Duchenne's, Obviously, you got to know the difference between Duchenne's and Becker's. You know, again, Becker's is just, it's not nearly as bad as Duchenne's. Duchenne's obviously deletion of the dystrophin gene. That's the longest gene in the body. And Becker's is just more of, again, a milder form. Hunter's, didn't really memorize that one too much, just put it in the category. And of course, hemophilia A and B. If you obviously watch the Pathoma videos, he does a really good job understanding the flow of 12, 11, 9, 8, 10's in the middle, 7's on the right, and then I think like 5, 3, 2, or whatever it is. But anyways, we can always cover that when it comes to the blood disorders, but know the category. And then X-linked recessive, that was it. X-dominant, a lot shorter category, but you can see it's again, at least one parent of either sex is affected, and all female offspring of affected males have the disease, okay? And then the key ones with this is going to be vitamin D, and then it's going to be the Fragile X, okay, the Fragile X. And again, Fragile X, CGG, okay? Too much CGG leads to the hypermethylation. Hypermethylation, that's a key. And gene inactivation. Remember, the methylation mutates. It silences. It mutes. And then our mitochondrial inheritance. Remember, it's the mom. Everything, mom gives it to all the kids. Dad does not pass it. And then that's where you have those Leber-Lee syndrome and myoclonic epilepsy with red ragged fibers, MRF syndrome. Okay, those are the big three. But be prepared for a question on mitochondrial. Okay? And then, of course, Downs, and I'm going to stress this during the questions, is that, see where those arrows say down, up, down, up? Alpha-fetoprotein, beta-HCG, and estriol inhibin A, those are all alphabetical. And so they're going to ask you a question on the quad screen about someone potentially at Downs, and you'll know whether things are elevated or decreased based on that. Down, up, down, up, down, up. And then again, meiotic non-disjunction, Robertsonian, second most common, and you can see the notes down there below. I don't need to read those to you. Okay? So let's get into the questions now. All right, guys, so here goes our genetics questions. The first one reads, an 8-year-old Caucasian male with repeated sinus infections and earaches presents for follow-up exam with his parents. You review the data and there is significant membrane potential difference in the nasal passage. The father reports his eldest brother had similar findings before he passed at a relatively young age of respiratory infection. Which of the following is most likely associated with the patient's condition? So, in step one, when something like this, and it just kind of, gives you all the clear indications that this is cystic fibrosis, you really have to know where they're at as far as what part of the body is the question asking about. So let's take a quick step back and let's just review this, because this is important when it comes to any cystic fibrosis question that you have. So cystic fibrosis, you need to ask yourself, where am I at? Are they talking sweat gland, or are they talking anywhere else, such as lung, pancreas, nasal passages, anywhere, okay? Anywhere else besides the sweat gland, because, I'll put all else right there, because there's a big difference between how cystic fibrosis affects either of these. So when it comes to the sweat gland, you need to look at it like this, okay? You have sodium and you have chloride, right, into the sweat gland, and then you got these channels right here, right? These channels are the CFTCR, stands for cystic fibrosis transmembrane conductive regulator, okay? Long story short, CFTCR. Now what happens is chloride should be going through here, and then some of the chloride goes through here, and then some of it gets put out into the skin, into the sweat gland. So, but what happens when these guys are defective, that the chloride doesn't go through, more of it gets pushed out here. So instead of it normally looking, say, like this, when this guy's all messed up, that means chloride has nowhere to go. It gets blocked, so it gets pushed out, and so you have more chloride. And of course, sodium wants to follow the chloride, so now you have a higher concentration, they call it hypertonic, out here. And of course, where sodium goes, water follows. So again, in the sweat gland, the problem is this channel right here is all messed up, and so everything gets pushed out, and you have more chloride, more sodium out here. Now, everywhere else in the body, you got to look at it like this. Okay, you have the sodium and the chloride, and say we're in the lungs. Okay, and normally these guys should, it's kind of like an exchange coming back and forth, kind of in a balance. Well, again, cystic fibrosis, this isn't working. So the chloride can't get out. Okay, it can't get out. So if it can't get out, then the sodium stays with him, right? And then this other channel allows sodium to kind of swing back in. And so where sodium goes, the water follows, so you get more of this here. And so what do you think the fluid on the outside? It is going to be thicker. Okay? But in this one, remember, the chloride, it can't, think of this, it can't escape. Okay? It can't escape. And if it can't escape, everything stays in. The fluid is thicker. But you see the difference? In the sweat gland, everything got out. But in everywhere else in the body, these guys can't get out. Okay? So that's a big difference. And you just have to understand that there was, in terms of absorption and secretion and things like that. But two different things, sweat gland versus lung. So now let's apply that to this problem. Again, 8-year-old, he's got repeated sinus infections, earache. So we know it's the cystic fibrosis. There's a little bit of a genetic component there. But where are we at? We're in the nasal passages. So which one applies? That's the one. It was like this, right? And so if we're here and we're in the nasal passage, which of the following is most likely associated with the patient's condition? Is it increased chloride secretion? Oh no, that would have been the sweat gland, right? That would have been the sweat gland. So I know it's not that one. Now, if this would have been a sweat gland thing up here, you would have said, yeah, you would have jumped all over that. Is it decreased sodium absorption? No, well, because again, that's the sweat gland. Because remember, as chloride should have went back, so the sodium would have followed him absorption back. And so if it was a sweat gland, it would be decreased. So it's not that one. Increased sodium absorption. And see right here, remember chloride had to go back, and so did the sodium. So that one's looking pretty strong, okay, because it's increased absorption going back in. Increased potassium, decreased potassium, no, we never talked about potassium one single bit when it comes to the cystic fibrosis. So do you understand this? This is a key point, that if they're talking sweat gland, and that's where the question is, you got to be thinking this. If they talk anywhere else in the body, you better understand that it can't get out. Okay? And then, say when it can't get out, you have a big difference in membrane potential, right? Because all the sodium ion, the chloride ion, they're all on the inside, and there's not as many on the outside. So there's a big change. There's an increase in that differential right there. Okay, and that's what they're talking about here. They're saying there's a significant membrane potential difference. So I knew I was right here. Okay, again, it's the difference between the ions on the inside versus the outside. All right, the patient's condition can be diagnosed by which of the following? And sodium levels in the sweat. No, we used to always think it's the chloride. The amount of cilia in 1 cc of sputum. No, we didn't talk about that. Sputum culture. That's not how I do it. Chloride in the sweat, looking good, right? That's the one that we have for the that kind of confirmed cystic fibrosis. There's actually, gosh, I wish I would have wrote this down. I think it's that IRT, immunoreactive trypsinogen. Anyways, they do this one because that's where there's some, I guess, inflammation or whatnot in the pancreas, and then you would confirm it with the chloride in the sweat. Or pulmonary hypertension. Nope. That was the one that got me in trouble when I made this last time. So the correct answer is going to be chloride in the sweat is how you would confirm it. But the big takeaway from this page is know the difference between sweat gland and everywhere else in the body. Now this one says, a 16-year-old Caucasian male with respiratory infections with Pseudomonas presents for evaluation. The patient had a brother who had recurrent earaches and sinus infection. Parents are inquiring about treatment options. Which of the following would potentially improve the patient's condition? Well, Pseudomonas, your respiratory infections, and there's some inheritance with this. Again, you're looking at cystic fibrosis. I mean, again, this is kind of our topic now. Hopefully they'd give you more clues. Again, sinus infection, earaches, all that stuff. So out of all these answer choices, which one would be more treating the cystic fibrosis? And then you would jump all over pancreatic lipase. And then, how that kind of works is when you think about it, so if this is the pancreas, all right, and there's pancreatic duct, is that, remember what we said, when the chloride and the sodium don't get out and more sodium kind of follows back in, this fluid becomes thicker. And if I have thick fluid in here, then there's going to be some inflammation. The pancreatic enzymes aren't going to be able to get out, right? And then therefore you're going to supplement with some pancreatic lipase, so that's going to be your treatment for that. Which of the following is associated with the transmembrane dysfunction for this condition? I didn't do a good job covering that, but this is just strictly probably just a memorization at this point, that these channels are going to be ATP gated, okay? ATP gated. And we'll do a video in the future describing all the different type of, I'd say, receptors when it comes to how things are. ATP gated, G protein, that's huge, but we'll cover all those in a later video. So for right now, just remember cystic fibrosis is going to be ATP gated. And this one says a 7-year-old male with recurrent respiratory infections is found to have absence of the cystic fibrosis conductance regulator. That's that guy we were talking about, right? That's the channel thing. On the epithelial surface. Okay, so where are we at? We're on the sweat. So which of the following would have hypertonic fluids on their surface? Okay, it was almost pretty much a giveaway there. But they're talking hypertonic, right? More ions in there. So again, if I'm in the sweat gland, what happens? Chloride, sodium. Chloride can't get out, so more gets pushed through. And where chloride goes, sodium's gonna kind of follow him, and of course water's gonna follow them. So where's it gonna be more ions per se, or hypertonic? It's gonna be in the sweat duct, okay? Because remember, on this one on the surface, it's just gonna be, everything stays in, so it's gonna be thicker fluids outside, okay? But all these ions are gonna be in the sweat gland. So you're going to say sweat duct on this. Plus, look at these. Pancreatic duct, large airway, this is lung. These are all in the same boat. And then as far as a vas deferens, remember, in cystic fibrosis, there is an absence. Okay? Which of the following is the patient most likely to die from? And again, in cystic fibrosis, think about this, is like, say if I'm in the lung, right, and then say normally in the lung you should have those cilia, right, and they should, if you inhale something like a bug, it should kind of move it, and you cough it on out. But if there's thick fluid, right, if there's thick fluid in the lung, you're not going to be able to kind of move those things on out. So which of the following is the patient most likely to die from if they have the cystic fibrosis? You're going to say respiratory infection. This one says, a married couple presents to primary care provider for prenatal consultation. The husband stands 120 centimeters, 48 inches tall, with average trunk size and enlarged head. He is adopted. His wife stands 163 centimeters or 64 inches with unremarkable family history. What are the chances that their child would be short stature? Well, you got this guy average trunk size, right? So it's like the head and the trunk are all normal, but the limbs are shorter, okay, and 48 inches tall. So this guy has got achondroplasia, okay, and because you memorized it, that's going to be autosomal dominant, okay, autosomal dominant, and from that, you have to know, you're going to throw it in there because you get a lot of these questions on the STEP exam as far, well, not a lot, but chances are you will see that, to where someone comes in for counseling and says, what are the chances of us having a kid like that? So let's just think, if this guy is, he's got one, say, bad gene, achondroplasia, and then he's got a good gene, and then his wife has, obviously she's normal height, so hers are okay. You just do the Punnett square and say, what are the chances of the kid being short with the achondroplasia? And obviously it's going to be 50%. So, and that's because it's autosomal dominant. Now you would say, well, how do I know this guy? How do I know this guy's achondroplasia doesn't have two bad genes, right? Because then it's almost 100%. Well, essentially because you know that if someone had achondroplasia and they had both the genes, chances are that they would not, they don't really, it leads to death, as we should say, okay? So if they have both the genes, it leads to death, so they're not going to make it to adulthood and stuff like that to reproduce. Achondroplasia, like we talked about, fibroblast growth factor R3 gene, okay? And so homozygote leads to death, so the right answer here is going to be 50%. Again, autosomal dominant. Know the scenarios when it comes to married couples coming in and asking about what are the chances of their kid having this condition. This one says a newborn was born to a 42-year-old woman, has epicanthal folds. The newborn has flattened facial profile and nose. Of the following choices, which is to have the most likely occurred prior to conception? So anytime you see kind of a woman, over in her 40s having a child, you gotta be thinking Downs, okay? And then they throw this epicanthal folds, on there with you, so flattened face. So we know it's Downs. So which is the most likely to have occurred prior to conception? Now, when you look through these, Robertsonian, expansion of the trinucleotide, methylation of one chromosome, meiotic non-disjunction, and you just better flat out know that it's going to be meiotic non-disjunction. That occurs in 90%. And then that's basically 3 copies of chromosome 21, not just the 2. And, the second one, a lot of times they'll say, what is the second, I don't say the second most common, but they'll say the issue isn't that they had 3 copies of 21, that there might have been where one kind of merged in, and then that's where you'd be going with the Robertsonian, which is the number 2. And really on that one, they say part of chromosome 21 becomes attached, okay? It becomes attached to another chromosome. And that's what creates the issue in Robertsonian. And it's usually chromosome, I had to look that up, 13, 14, or 15. Okay, I'm not saying you got to memorize that. You just got to know Robertsonian is going to be the second, and the issue wasn't the 3 copies of 21, because that's meiotic non-disjunction. Okay, and the second most common, again, Robertsonian. The thing with Downs, and I know I stressed this when you were learning it, is I remember I said you need to learn down, up, and you're saying why? Because I'm guaranteed you're going to see this somewhere in there. Down, up when it comes to Downs, because alpha fetoprotein, beta HCG, estriol, and inhibin A. And if you notice, A stands for alpha, okay, or this guy, B, E, I. It's all alphabetical, left to right, right? Alpha, beta, E, I. Alphabetical, down, up, because you'll know if they give you the lab work for a mom who comes in with some type of quad screening and they just give you the estriol or they give you the diagnosis and you got to work backwards, you'll know that the beta HCG levels are elevated, the inhibin levels are elevated, the estriol and the alpha fetoprotein for Downs is decreased, okay? Down, up. Put them in alphabetical order and you'll always get them correct. Downs associated with duodenal atresia, okay? Associated with ALL, okay? And early Alzheimer's, right? Because we said that is amyloid precursor protein on chromosome 21. And well, since they got 3 copies of them, they got a little extra Alzheimer's risks there. This one says a 26-year-old male is being evaluated for a recent epileptic episode. He has suffered from hearing loss and muscle weakness. He is adopted, and there is no knowledge of family history. Muscle biopsy reveals Gamorre's trichrome stain. His wife asks, "What's the probability of their children that their next child is at risk for this condition? What is the probability that their next child will inherit this condition?" So the biggest clue on this is the Gamorre trichome, okay, which is mitochondrial myopathy, okay? And you just know, because you memorized it, because you memorized all the categories, that is obviously it's in the name, of mitochondrial inheritance. So what are you going to do? What's the answer? It's a 26-year-old male. So therefore it is 0% chance. Remember, mitochondrial only comes from the mom, okay? Mom passes it to all her kids. Okay, whenever you see that, you got to be jumping on mitochondrial. It's a very popular question that they put it male. Okay, I've seen it. I'm just telling you, it's there. So be aware and don't be tricked. When you see mitochondrial, there's only like 3 conditions that we typically look at on that. But if you see this Gamori stain, think of it, and then make sure if it's a male, put 0%. A young professional female comes to her primary care with concerns for hair loss. Multiple members of her family have had similar issues with hair loss. Which of the following conditions has the same inheritance pattern as the one mentioned above? All right, so we know that we're talking about androgenic alopecia, okay? And we know that that's autosomal dominant because we've memorized everything, okay? You gotta know the categories or you're dead in the water. And then they're just asking which one's in the same category, okay? Strict memorization, but you gotta be aware that they could ask it like this, okay? They give you a question, they assume you know the diagnosis, assume you know the inheritance pattern, and then you gotta match it. Beta thalassemia, autosomal recessive. Cystic fibrosis, for the most part, autosomal recessive. Wiskott-Aldrich, X-linked recessive. Fragile X, X dominant, and of course neurofibromatosis, autosomal dominant, okay? I like the way this question is kind of asked. It's multi-step, really kind of test your knowledge. You know, do you make the diagnosis, know the inheritance pattern, and you got to know all these differentials too, okay? And this one, it says, a 28-year-old Caucasian has a history of needing blood transfusions. His family pedigree is as follows. Okay, so we see a bunch of males, and then it skips generations, so we know it's recessive, right? And so, you know, recessive, there's no male to male, so we know this is going to, yeah, we know there's no male to male, so we know we're going to go with X-linked, and we're going to hit on X-linked recessive, obviously, because we know that. So anyway, this is kind of an overtly simple one. So back to this, I would say if there's a big takeaway from this lecture is know how to memorize the categories, but then understand the difference in cystic fibrosis, whether you're in the sweat gland or the lung, and I think you'll pretty much nail any question that they could ask you. So hope this helps, guys.